Welcome to Mercy Medical Center's live webinar. Today we will be discussing molecular breast imaging, or MBI. Joining us is Dr. Laura Hemann, Medical Director of Mercy's Women's Center. After her discussion, she will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Well, welcome to our webinar, Dr. Hemann. I'm going to turn the mic over to you now so we can go ahead and get started.
Thank you, Lynn, and good afternoon, everybody. I'll talk a little bit here about molecular breast imaging, and then, as Lynn has said, we'll have a little time for questions, hopefully. So what is this test or procedure? It is called molecular breast imaging, and the acronym for that, of course, is MBI. Another term would be Lumagem, and that is more of a trademark name, but the GEM stands for gamma emission mammography. Most of what we're comfortable with radiology is going to be studies which are done utilizing common X-ray evaluation. This test is different because we're using a gamma emitter radioisotope. This isotope, which is commonly used for cardiac imaging, is called technetium-99m sestamibi, and this is paired with a dedicated gamma camera, and this allows for functional breast imaging. These are a couple of pictures of the system. On the left, you'll see the system looks very much like a standard mammography platform. This head is able to rotate around to get various images. The breast is placed here, very gently compressed between these two plates. This is actually an upper gamma camera and a lower camera. Imaging is performed from both sides of the breast simultaneously, and this is different from mammography, which is just utilizes imaging on one side of the breast. This is just a close-up of that dual-headed gamma camera, the upper plate, upper gamma camera, and the lower gamma camera down here. And then this axis is able to turn as needed for various images. This is a picture of a woman, an actual woman who you don't see the breast obviously, but it would be placed very gently between these two cameras. Technologist is going to do the positioning, and once she moves out of the way, the woman will actually be looking through this aperture with the television mounted over here on the wall, and that is allowed to keep her attention during the procedure time. Once the patient receives this low-dose injection of technetium-99m sestamibi by IV, which is usually placed in the forearm or the elbow space, imaging is begun within 5 minutes, so there really isn't any wasted or downtime with this procedure. The radiotracer is going to preferentially accumulate in cancer cells, and I'll show you some examples, but understand that it does accumulate to some extent in normal breast tissue, and this is what allows us to actually see the outline of the breast and to compare and contrast the molecular images to the woman's mammogram images. So the breast is just gently compressed lightly between the gamma cameras. This is only about a quarter of the pressure which is utilized in mammography. So women who have very sensitive breast tissue would find this a much more comfortable study than a routine mammogram. So the images that we get are functional images, and we get images of each breast which are depicted as the routine views that we get with mammography. This is MLO, or medial lateral oblique, and CC, or cranial caudal views. One of the big differences between molecular breast imaging and mammography is that MBI is not affected by breast density. Density of the breast tissue is a measure of the glandular tissue of the breast relative to the fatty components. And this can vary considerably between women. I will show you a few examples. Dense breast tissue is the main limitation of mammography and can render our job as breast imagers extremely difficult on a day-to-day basis. Here's just a standard two-view digital mammogram. The cranial caudal views of the right breast and left breast are here, and this is the side picture, or medial lateral oblique view. On this image, we're going to see the nipple out here to the front of the breast. This is the upper part of the breast and the lower. This, of course, is the pectoralis muscle, which connects our chest wall to our shoulder and upon which the breast sits. These breasts actually have a kind of a medium amount of fatty versus medium amount of fibroglandular tissue. The black or gray structures of the breast are going to represent all the fatty components, and anything that's white is going to represent the fibroglandular breast elements, the ducts and the lobules, and the supporting tiny ligaments which give the breast its shape. So these mammograms are interpreted as normal. You notice there's a little bit asymmetrically dense, more fibroglandular tissue in this lower confines of the left breast than compared to the right, but these are considered completely normal. Now I'm going to show you the corresponding molecular breast imaging study of that particular woman. Again, we're going to have an upper camera and a lower camera, so the right breast will have 2 images instead of only 1 that we see with mammography, and that's going to be happening for each view. So we get 8 images to look at instead of only 4. And this is what the normal breast will look like. You can obviously see the outline of the breast, and it corresponds very nicely to the mammographic views which are shown with mammography. The nipple sometimes will show uptake. In this particular woman it doesn't, but very often it will. And usually you'll get a little bit of uptake in the pectoralis muscle on each side. So what we want to see is just this uniform specular pattern throughout both breasts, which is fairly homogeneous. The breasts are symmetric from side to side, and neither breast demonstrates any increased areas of activity. I'll show you an example or 2 of ones which do, and then it will be very easy to see what a cancer would look like. But this is just a normal study. Here is a breast that has quite a bit more dense or fibroglandular tissue than the one that we just saw. She's going to have a small amount of fat in the immediate subdermal location, and then the rest of her breast tissue is extremely dense with only small amounts of fat interposed. These mammograms can be extremely difficult for the radiologist to interpret. If you think about a small cancer in here, it would have the same density generally as normal breast structures. You would have to rely on seeing some architectural distortion or a little bit of unusual calcifications to indicate a malignancy. So in a breast like this, it's very hard to see a cancer. But these are considered normal, and I'll show you the corresponding MBI that goes along with this set of mammograms. Again, upper camera and lower camera in each of these views for resulting 8 images altogether. And you will notice that this woman's nipple uptake is a little more dramatic than the one that we saw previously. This is normal. And rather than having increased uptake where the breast tissue was densest on the mammogram, this one actually exhibits what we call photopenic area. The denser breast tissue has actually less activity than some of the normal or fattier elements of the breast. This is called the photopenic pattern. This is a normal pattern. It actually means that this woman, although her breasts look very dense on mammography, she actually has a lesser chance of a breast cancer because this part of the breast is functioning less than the other less fibroglandular elements. What are some of the best uses for MBI? Well, obviously we would like to use this as a problem-solving tool in the evaluation of women with inconclusive mammography and or breast ultrasound findings. MBI can be used on a daily basis in women as we see them in the diagnostic clinic during the day, which we do Monday through Friday here at the hospital. Obviously, we could use this technology to evaluate whether a lump in the breast is normal or tumor. Very often, either a woman or her provider will feel an area in the breast on clinical exam that's a little bit equivocal. Well, is this just a kind of a lumpy, bumpy breast tissue in a woman with fibroglandular tissue, or might I be feeling an actual tumor? This is another good indication for MBI. If the molecular breast imaging study is completely normal in these cases, which I have shown you this morning, then it doesn't much matter how the breast feels clinically. There's not a tumor in there that would be something to consider abnormal. And lastly, we would like to be able to screen women with very dense breasts and use MBI as an adjunct to mammography, which could conceivably be done on an annual basis. I'm going to show you an example here, a couple of examples of women who have breast cancers. This woman has extremely dense breasts in the central cone of the breast. The X-ray beam has to really over-penetrate the fatty elements of the breast in order to show us to show us all the way through the denser components. So even her skin is almost burned out, and this is a common finding with either digital or standard film screen mammography. But in this particular woman, I can tell you that when comparing to this mammogram to her previous, there is a suggestion of a little bit of potential architectural distortion up here in the upper outer aspect of the left breast. And the area of concern potentially on this image, CC image, was a little area over here which looked a little bit denser. So it's kind of like finding Waldo, but instead of him having on his red and white striped shirt or hat, he's just gray and white like anything else going on. So the mammographer's job every day is very, very difficult. So I'm going to show you next the MBI that goes along with this set of mammograms. Okay, very easily you can appreciate this little light bulb that's showing up here in the left breast, outer breast, slightly to the upper part of the breast, and this does correspond to that very subtle area on her mammogram, which was equivocal at best. This on histologic biopsy was an invasive ductal carcinoma that measured almost 2 centimeters in size. So a very, very equivocal mammographic finding. You'll notice also that this woman also does show the photopenic breast pattern, which is common on an MBI. But in case there are any skeptics in the audience that thought, well, that dense breast tissue just isn't actually being penetrated by the molecular gamma rays, that's actually not the case. The cancer shows up very well, even though it is in an otherwise photopenic or underfunctioning area of tissue. Going to move on to our last case that we'll show this morning or this afternoon. This is an older analog or film screen type of mammogram, so overall it's a little bit underpenetrated. The fatty part of the breast actually look gray rather than black, and the outline of the skin is not as well seen as what we would generally see with a digital mammogram. This is called the retroconal fat back here, and it's asymmetric from side to side. This side is normal because these are nice undulating contours with no sharp edges. Contrast that to this is a little cancer sitting back here in the retroconal fat of the left breast out laterally. And the reason you see this is because it is sitting in the fat. If it were sitting in here or even over here in the breast, you would see that it would be much more difficult to see. It does have a few little microcalcifications affiliated with it, and that's also something the breast imager will be looking for. This is the little cancer in the MLO view of the breast. So in this one, there really wasn't a surprise. This looks like a cancer, and of course it is a cancer, but the findings on this mammogram actually involve the lymph nodes as well. I'm going to take it to the left breast. This is a normal little lymph node. It's kidney bean shaped, has a nice little uniform cortex and a little fatty area inside of it called the hilus. That's very crucial that these be seen in a relative symmetric ratio. Here's a larger lymph node, but see it's got a very large normal fatty hilus within it. We don't see it in its entirety, but the cortex appears fairly symmetric. Now over here in the breast that's got the little cancer, this lymph node in particular is very suspicious to radiologists' interpretation. The fatty hilus is pretty small, and the cortex is big, thick, asymmetrically thickened, and kind of lumpy bumpy. Some of these smaller lymph nodes also are fairly dense, and some of them don't reveal fatty hyla. So we're going to go ahead and do some specialized imaging with molecular breast imaging. We're going to center a little bit up here so that we can evaluate these lymph nodes as well as the cancer in the breast. Here's the corresponding molecular breast imaging study for this woman. This is her arm raised up. We're well up into the axilla. Here's our little cancer on both views. You'll notice that even on the CC view, we've offset to the lateral aspect of the breast. She obviously had additional MBI views, which would have looked at the other part of her breast on both of these views. But this is just to show you two things. Number one, we can utilize MBI with special mammographic, just as we would with special mammographic views when we have real estate that we really need to see outside the constraints of what we normally look at. And these lymph nodes are all abnormal. Each and every one of these shows increased uptake of the radiotracer, not quite as intense, but still fairly intense compared to the lymph node. Contrast that to the lower part of the left axilla where everything looks normal. So this is very important to know. This very tiny cancer has already metastasized to numerous axillary lymph nodes. This is very important for surgical, radiation therapy, and medical oncologic purposes. So that's my last example of images. Wanted to show abnormal as well as normal studies. So once again, just to recap, the best uses for molecular imaging definitely is a problem-solving tool in evaluation of women with inconclusive mammography or ultrasound findings to evaluate whether a lump in the breast is normal tissue or tumor, and potentially to screen women with very dense breasts as an adjunct to mammography. Now, why is that important? Women with increased breast density have a 4 to 6-fold increased risk of development of breast cancer compared to women with fatty breast tissue, and these women obviously, as I've shown here, have an increased risk of having a false negative mammogram. Everything might look normal or unchanged to us, but depending on how big and where that cancer is located within a dense breast tissue, we could possibly miss observing that altogether. Now, another fact to take home is that up to 40% of all women have dense breasts. This is regardless of the woman's age. Most of us think of dense breast tissue as something of younger premenopausal women, but that is not necessarily the case. We see many, many postmenopausal or even elderly women into their 80s who have extraordinarily dense breasts, and makes mammography extremely difficult. Now, what's the overall sensitivity for finding a cancer? It's about 80% overall, and it's the best test that we have at this point. But that means that up 15 or 20% of women might have a cancer in the breast that mammography just cannot find. If you contrast that with women who have extremely dense or dense breast tissue, the sensitivity of mammography plummets, and it can be reported as low as 27%. So that means that our gold standard test isn't very good for that subset of women, which, as I said, is up to 40% of all women of any age group. If you add an ultrasound of the breast to a mammogram, you're going to increase the sensitivity to find a cancer moderately, up to 87%. But breast ultrasound is very time-consuming, it's very operator-dependent, and it's very hard to apply across a screening program. Molecular breast imaging and mammography dramatically increases the sensitivity of finding cancers up to 93%, and in some studies up to 98%. Conversely, the negative predictive value of MBI is 98%, which means that if you do an MBI on a woman, regardless of whether there's something that feels lumpy in the breast, regardless of how the mammogram looks, if the MBI is negative, then this woman has less than a 2% chance that a breast cancer has been missed or not diagnosed. Mayo Clinic is doing a lot and has done a lot of the research studies for molecular breast imaging. They're actually the institution that developed the new dual-headed gamma camera that we utilize here at Mercy Hospital, Cedar Rapids. There are only about 15 of these units out in the entire country, so we're quite on the leading edge here at Mercy to have this technology. Mayo Clinic has studied 2,500 women who had dense breast tissue and an above average risk, either a family member with breast cancer or a previous biopsy of a premalignant condition or something on that order. MBI in this group of women found 3 times more cancers than the screening mammograms of these women did. So that's very telling information. G Komen Foundation has actually just finished studying women. The goal was to study up to 2,500 women who had dense breast tissue but had no other risk factors. This is going to use MBI as a screening tool and compare it to the efficiency of mammography to find cancers. After enrolling only 1,600 women, the 20 cancers which they felt were going to be an adequate sampling were found in only 1,600 of those women, and so the study was actually closed so that it could be published. In this subset of women, 20 cancers were found, and only 6 of these were found with mammography. So we're finding that MBI tends to be at least 3 times better. The MBI tends to be at least 3 times better than mammography in finding cancers in women with dense breasts. So hopefully, not only will it be an effective problem-solving tool, but in the near future, I'm hoping to be able to utilize this as a screening situation in women with dense breast tissue. Thank you so much for your time and attention, and I'll turn this back over to Lynn for some question and answers.
Well, thank you, Dr. Hemann. Your slides were very helpful in understanding MBI and how it can help identify the cancer. Just to remind you, your questions can be submitted from the box in the upper right-hand corner of your screen. If you don't see it, you can just click on the orange box and we'll go from that. Our first question will be, well, we have a lot of questions to get here through today. Let's begin. The first one, Dr. Hemann, can you tell us what factors really determine breast density and how much of that is determined by weight or body type?
That's a very good question. Most of this is actually genetics. Women either do or do not have dense breast tissue, and really their body habitus isn't necessarily going to be a big factor. Sometimes very obese women will have relatively fatty breasts, but there's not something that we see across the board. And conversely, women who are skinny can also have relatively fatty breast tissue. So this is primarily driven by genetics. We do tend to, and for the last 2 years, have made a distinct effort here in the Cedar Rapids area to report breast density in our mammogram reports for each and every woman that has a screening mammogram. And this, I think, is very helpful to the providers in the community. If, as an individual, you wonder if your breast tissue is dense, and if you are at risk, you might just want to talk to your provider, and she could give you that information based on your mammogram report.
We have another question that's similar to that, but I'm going to go ahead and make sure that we answer this question also. Does having large breasts increase your chance for lumps in the breast or for cancer? And the question is, when I do individual breast exams, it's hard to tell if what I'm feeling is normal dense tissue or something harder like a tumor.
This is also a very interesting question, and what we find is that since the breast, if you think about it, are composed of not only the fibroglandular elements but variably sized fat lobules, breasts can feel clinically extremely lumpy, bumpy, and they could actually look very fatty even on mammography. The fat lobules are each enveloped by a small amount of connective tissue, which makes the breast have a little shape. It's got to have some three-dimensional things going on in there. And there are a lot of little supporting ligaments which connect the breast tissue itself to the skin. So breast clinical examination does not correlate well to the mammographic findings. And lumpy, bumpy breasts that feel very firm on clinical exam are sometimes extremely fatty, and vice versa. Very, very soft feeling breast clinically can be very, very dense on mammography. So it's very hard to know.
We've had several questions related to insurance and does insurance cover MBI? I'm going to read a couple of these. For those whose insurance will not pay for further testing after discovering dense breasts on a mammogram, are there any funds available? Or is there any way to get insurance to pay for this test?
Well, payment for MBI has been extremely frustrating for me, and I continue to work with Wellmark Blue Cross Blue Shield and other providers. What we do know is that Medicare does pay for the molecular breast imaging examination in the diagnostic setting, so that if we are working with a woman who is within that age group and we're having to do a problem-solving mammogram and or breast ultrasound, if that woman happens to have Medicare insurance, then I liberally recommend molecular breast imaging in that scenario because I know that it is paid for. Currently, the self-pay proposition for a woman is that the test costs about $539, and I'm going to break that down for you. The first part of that charge is for the actual radioisotope. Whether you are having a breast evaluation with MBI or a nuclear medicine cardiac study or a gallbladder evaluation, part of the charge for any of those tests is what the radiotracer itself costs. The second part of that is obviously the procedural charge for doing the procedure itself, which takes about 45 minutes in this case. And thirdly would be the reimbursement for interpretation of the study by the radiologist. What Mercy Hospital has done is they have incorporated all three of those charges into one self-pay scenario, and that is $539 altogether. So the woman does not get individual bills from radiology and another from hospital, another from lab. This is all wrapped into one charge. I do continue to work advocating for payment of MBI, at least in the diagnostic setting, with Wellmark Blue Cross Blue Shield in particular. They have been waiting with great interest in the latest research study from the Mayo Clinic to come out and get published. And even though that particular research study had to do with the screening setting, not the diagnostic setting, I am still hopeful that this time next year we're going to have some payment, at least in the diagnostic scenario.
Very good. Be hopeful that we do get responses. Another question, if you have larger, dense breasts, should you get an MBI screen sooner than the normal recommended age?
Basically, I would say no. The guidelines set about for having your baseline mammogram between age 35 and 39 would still come into play. After the age of 40, of course, we advocate that women have their mammograms every single year. If you have very large, dense breasts versus a woman who has very small, dense breasts, then I guess you could say just because there's more tissue in one person, that person might be a little bit more apt to develop a breast cancer than a woman who has only a small amount of breast tissue, but that's a very difficult thing to study. But we do know that the guidelines are appropriate, and unless you have a very positive family history of breast cancer in multiple individuals, those are the only subset that would actually need their mammograms to begin earlier. And in that setting, we would say the woman should have her baseline mammogram 10 years prior to the age of diagnosis of the youngest family member diagnosed. So if you had a mother with a premenopausal breast cancer at age 45, you might consider annual mammography starting at age 35.
Okay, next question, Dr. Hemann. What is the difference between MBI and 3D views? What are the pros and cons of each? What is the cost of each? And do they address different issues? So several questions wrapped into one here.
Certainly, because molecular breast imaging is functional, it's going to differ substantially from anything that's showing us anatomy. Obviously, routine mammography is anatomy, 2D anatomy. People talk about tomosynthesis, which is actually not quite 3D. It's almost more like a CAT scan of the breast, where instead of just looking at it as a slab volume of tissue, you're taking individual cuts through the tissue and adding them all together. That, however, is still anatomy, and it's not function, and so there are very obvious differences. Pros and cons. Well, mammography is obviously much less expensive than molecular breast imaging at this time, and it's paid for by and large by insurance. So that's the biggest cons of having the molecular breast imaging done. They do address different issues, as I've said, with mammography, whether it be 2D or tomographic or 3D, still showing only anatomy, whereas molecular is going to show function.
Next question, I had an MBI in August, which is negative. My question is if I should go ahead with my annual mammogram in January. What is the radiation risk with MBI, and can it be used annually instead of mammography? Great question.
That's a little bit of a 2- or 3-part question. We recommend breast imaging annually. Since right now the gold standard for breast imaging on an annual basis is mammography, yes, I would recommend that to stay on schedule, you go ahead and have your routine annual mammogram in January. That's just so that you stay on schedule. If we are able to start offering molecular breast imaging on an annual basis for women with dense breasts in the screening scenario, then what we would try to do is have that woman also have an annual mammogram every year. These could be alternated at 6 months apart from each other, which would actually mean the woman's having her breast screened every 6 months, which would be a fabulous thing. But until we start having some payment on a screening basis, we're really not going to be able to bring that into play. As far as radiation goes, I can tell you that the dose that we use, the dose of sestimib that we use for molecular breast imaging currently gives a slightly higher dose than does a digital mammogram. It's about double, but it is still a very low dose. The screening study that Mayo Clinic has just completed and which we're expecting to be published about February or March actually brought that dose down to half of what we're using currently, and this dose would then be equivalent to the breast dose that a woman would get with a digital mammogram. So yes, the radiation dose would, the radiation risk would be no more than it is for mammography, so there's definitely the benefit is outweighs the risk, and then we would certainly be able to offer the MBI to a woman on an annual basis. Now, why do we still need a mammogram if we are looking at function instead? The only time that the molecular breast imaging study missed a cancer, it was a 5 millimeter DCIS, or stage 0 cancer, which showed up on a mammogram as a tiny group of microcalcifications. So this is the main reason that we would still advocate for mammography on an annual basis, is because we would be looking for calcifications on the mammogram, which might show something slightly below the resolution of the MBI. 5 millimeters is extremely small for any nuclear study, and that is the rationale to still have mammography annually.
Okay, very good. I'm going to move the screen ahead here so that if you have additional questions, Dr. Hemann is available, could be reached for additional questions at 319-398-6690. Okay, another question came in. Are there any funds available through Susan G. Komen or other programs like that that would pay for this test?
Great question. At this point in time, no, I don't think so. However, there are the Especially for You funds propagated here through Mercy Medical Center's annual race. If a woman happens to qualify for Especially for You funds, she would obviously be able to use those funds for any type of breast imaging procedure that we would think is necessary. That would include molecular breast imaging, breast ultrasound, breast biopsy.
Good. Thank you for the comment from someone who said, excellent presentation, Dr. Hemann. I want to point out our next webinar topic is Mercy Home Care Services, Know Us Before You Need Us, with Margie Pence, Director of Mercy Home Care Services. The webinar will be Thursday, November 8th from noon to 1, and she will take your questions live after the discussion. Again, I want to point out that if you have any additional questions about the topic of MBI, the number 319-398-6690, and there are brochures available at the Mercy Women's Center about this topic. Now, a tape of this program will be available at www.mercycare.org/live within the next day or two. And you can always check this website for information about future webinars and to listen to past webinars. I believe we have covered all the questions, so thank you all for joining us today.